Okay, just stop for a second. Picture this. It's a high-stakes dilemma right now. You're on the ward, reviewing a new admission. It's a patient who had a stroke just yesterday.
Mm.
And after they take a few sips of water, they start coughing. I mean, really coughing, struggling for breath.
Okay.
At the exact same time, the site manager is standing right next to you, pressuring you to get the discharge paperwork done to free up the bed. What do you do? What is the very first thing you do?
That's the crunch, isn't it?
Welcome to the deep dive. Today, we are focusing on, well, a critical skill. It's what separates proficient clinicians from those who just get overwhelmed, recognizing multidisciplinary team MDT roles and responsibilities.
Right.
And we're going beyond just knowing what an OT is. We're talking about how you coordinate the entire team for maximum safety and efficiency, especially when you're under that kind of pressure.
That's exactly it. We've taken specialized textbook notes, GMC guidance, and we've boiled it all down into one essential framework. The goal today is to give you the ultimate shortcut, what we're calling the central exam truth for MDT coordination.
And what's that truth?
It really boils down to this. Success is using the right professional at the right time. And that has to be backed by a clear SBAR ask, agreed upon timeframes, and, really comprehensive documented outcomes. It's all about achieving safety through structure.
So we're really targeting what high performance actually looks like here. It's so easy to get swamped in a complex situation on the ward, isn't it?
Absolutely.
But the high-scoring action, the safe action, is always about routing the job to the correct professional and doing it quickly. It's about giving a crisp, structured referral, setting a real timeline, and then meticulously recording who's going to do what and by when.
That is the difference. It's the difference between a patient staying safe and a patient coming to harm because of a system delay. And this is where the scoring logic really comes into play. When you face an MPT decision, the system rewards 3 specific behaviors.
Okay.
And if your action doesn't hit these 3 points, you're not just losing marks, you're putting the patient at risk.
So what's number 1?
Number 1 is role-matched action. Simple question. Did you pick the professional whose scope of practice actually fits the need? If the problem is swallowing, calling anyone other than speech and language therapy is just the wrong choice.
Okay, that makes sense.
Number 2, structured referral. Did you actually use SBAR situation, background, assessment, recommendation? And it's more than just saying the letters. It means giving a specific ask, flagging the urgency, noting any red flags.
And crucially, how they can get back to you, right?
Exactly, a closed loop. And number 3, owned follow-through. This is probably the hardest part in a busy hospital. You have to name an owner for the task, set a concrete time frame, not ASAP, but by 4 p.m. today, and then document the whole plan, including your immediate safety netting.
I really like that focus on ownership. It feels fundamental. It protects patients by preventing delays. It stops people duplicating work, which is a huge waste of time.
And it avoids dangerous scope breaches.
Right. So the core principle isn't, rocket science. It's just about mapping the needs, swallow, safety, mobility, meds, safeguarding to the correct role. But how do you remember to do all that when things are chaotic?
That's where you need a reproducible strategy. So we've distilled the sources into what we're calling the high-yield stepwise action framework. You can just think of it as a simple first, next, last sequence. It keeps you on the right tracks.
Okay, let's walk through it.
So step 1, define the outcome and the risk. What is the one specific problem that has to be solved right now? Identifying the highest risk, say aspiration, immediately points you to the right person.
So risk first.
Risk first. Step 2, select the appropriate role. This forces you to be really clear. Is it function in the home? That's an OT. Is it muscle strength and walking? That's a physio.
No ambiguity.
None. Step 3, refer with SBR and a clear ask. The person on the other end of the phone should know exactly what you need them to do and by when, without needing to call you back for more detail.
Makes sense.
Step 4, assign ownership and a time frame. This is so important. If 2 people are responsible, then really no one is responsible. You have to name the individual or the service.
Wow.
Dr. Smith, the registrar, will review by 2 p.m. It stops things from just drifting.
And the final step?
And step 5, document the plan, the outputs, and the safety net. This is all about continuity of care, especially for handovers.
Yeah.
It also gives you that clear audit trail showing you did your job safely.
Okay, that feels like a lot to hold in your head when you have, 3 bleeps going off at once.
It is.
So to make those 5 steps stick, the source material gives us a brilliant mnemonic. It's WHOTO.
WHOTO.
I like it. Let's break it down because this is your safety checklist. The W is for what outcome are we aiming for? H is for highest risk first.
Olev.
O is for optimal role, the best person for the job. T is for time frame, the deadline. And that final O is for ownership, who's chasing it, who's accountable. If your action covers WHOTO, you've nailed it.
Precisely. And the quickest way to use WHOTO is by spotting those high-risk scenarios, the red flags that demand an immediate specific MDT response. These are the situations where any delay is genuinely dangerous.
Like our opening dilemma.
Exactly like that. Suspected aspiration or an unsafe swallow. You can't waste a second. That means an urgent referral to speech and language therapy, or SALT. But what's your immediate action?
Making the patient nil by mouth.
Right away. The SALT referral is the plan, but NBM is the immediate safety measure. It's a dual action.
That's a great point. What about with medicines? That's another high-risk area.
A huge one. High-risk medicines or polypharmacy. This needs urgent pharmacist input. We're talking about things like opioids, anticoagulants, complex insulin regimens, and a key task here is therapeutic drug monitoring, TDM.
So that's for drugs like vancomycin?
Vancomycin, digoxin, yeah. They manage the dosing based on blood levels to make sure it's safe and effective. If you delay that, you're risking toxicity or treatment failure.
And then there's that constant pressure for discharge. That creates its own red flags, doesn't it?
It absolutely does, an unsafe discharge risk. If you realize a patient's home setup hasn't been assessed, or their ability to just, get dressed or make a cup of tea, that's an urgent safety issue.
So that's an immediate OT and physio call.
Immediate. Discharging without the right equipment or a mobility check is a direct breach of your duty of care. And the last big red flag is an escalating infection control issue. A neurovirus outbreak, a resistant C. diff. You have to get microbiology or infection control involved, and fast.
Okay, that makes the need for that rapid, accurate routing crystal clear. So let's get into the rapid fire guide to who to call. I hear so much confusion around OT versus physio, for example.
It's a common one.
So let's clarify the roles. First, the overall coordinator on the ward, the nurse in charge.
The NIC, the single most important person for managing the ward's workflow.
Right. They handle staffing, bed issues, reprioritizing tasks. You have to involve them early if you're making a big referral, otherwise you're just causing chaos.
You are. Then you have the pharmacist. They're the drug experts. They do medicines reconciliation, the IV to oral switch, TDM, and that crucial discharge counseling.
Now for the tricky one, the occupational therapist, the OT.
The OT focuses on function and adaptation. Think activities of daily living ADLs. Can they cook safely? Can they wash? They assess the home, organize equipment like grab rails, and really confirm that discharge is safe from a functional perspective.
Okay, so function. What about the physiotherapist?
The physio focuses on movement and restoration, strength, mobility, balance, gait. So if the OT is about the task and the environment, the physio is about the body and its movement.
That's a really clear distinction. And finally, the social worker or discharge coordinator.
They're essential. They sort out the community care packages, funding, making sure the equipment actually gets delivered. You can't send a patient home without that package being in place, no matter what pressure you're under.
And having that map is so essential because getting it wrong, misrouting, is a guaranteed low score.
And a patient safety risk, which is why we have to talk about the trap answers, the things the sources explicitly warn you against.
The low scoring option.
They're very clear about these. A classic trap. Ask the HCA to assess swallow. As we just said, that's a specialist SALT role. Asking an HCA to do it is a serious scope breach. It's dangerous.
I can definitely see how the pressure to discharge might make someone think about the next one, though. Discharge now, therapy later. Why does that fail so badly?
It fails because it puts admin efficiency above patient safety. If a patient is frail or has new mobility issues, sending them home without an OT or physio assessment is just knowingly creating an unsafe situation. Safety is non-negotiable.
What about distractors like order random tests first, so a patient falls, and instead of calling therapy, you order a CT head?
The failure there is delay. Yes, a CT might be needed later, but the immediate risk is mobility. It might be a drug side effect, an unsafe environment. Calling the therapist addresses the primary safety deficit first. Ordering a test just delays the right input.
And the worst of all.
The lowest scoring option always is to email someone to look, or just scribble a note in the handover. It fails on every level. No named person, no clear ask, no time frame. It's negligence dressed up as action.
So avoiding those traps really comes down to using precise language, doesn't it? Using model phrases that show you've covered all the WHO criteria.
Exactly. You need to show you know what to ask for and how to ask for it.
Okay, so let's use that opening dilemma. What's the model phrase for the SALT referral?
It needs to be crisp and specific. Something like SBAR to SALT. Situation. New stroke patient, coughing on sips. Background. Stroke yesterday. No prior issues. Assessment. High risk of aspiration. I've made him nil by mouth immediately. Recommendation. Please assess his swallow today, advise on safe diet and fluids, and call me on bleep 123 if anything changes.
I see how that includes the immediate action, the NBM, and the closed loop for communication. That's traceable responsibility.
It is. And for coordinating on the ward, your language needs to be collaborative but also directive.
So what would that sound like?
The good model phrase would be, nurse in charge, can we reprioritize the OBS in Bay 3 for about 10 minutes while physio does an urgent stare assessment for Mrs. A? I'll document the reason and let's check in at 4 p.m. to confirm the outcome.
Ah, so you've involved the coordinator, specified the task, and you've set that deadline, that 4 p.m. check-in.
Exactly.
That check-in brings us back to ownership, which feels like the most critical piece of this. How do you actually prove you've delegated something safely?
The sources are really clear on this. Ownership is proven by 4 elements that have to be in the notes. It's not enough to say, I asked physio.
Okay, what are the 4?
You need a named person, specific deadline,
Yeah.
the escalation thresholds, so what happens if it can't be done, and a checkback route. I will confirm with the NIC at 16/5/30. If any of those are missing, accountability is lost. You're culpable.
And this whole framework, it's not just exam theory, is it? It links directly back to your professional duties.
Absolutely. This is the practical application of core GMC expectations. First, the duty to work effectively with colleagues to keep patients safe. That means knowing what they do.
Right.
Second, the guidance on delegation and referral. It says you have to check competence and give clear instructions. That structured SBAR referral is how you do it.
And leadership.
And third, it's about leadership. Even as a junior doctor, when you clearly communicate roles, responsibilities, and escalation plans, that is a vital act of leadership on the ward.
Okay, let's tackle a couple of final sticky points. We said the NIC coordinates the workload. But if I refer a task, does that mean I'm no longer responsible for it?
No, not at all. You delegate the task, but you retain overall professional responsibility for the outcome. That's why that check-back route and the documentation are so non-negotiable.
And what about asking family to help? Is it ever okay to ask a relative to help mobilize a patient to speed things up?
That's a major no. Mobility plans are a clinical function. They have to be set by a physio or a nurse. Families can, of course, support the patient, but only within a documented plan they've been taught. You can't delegate clinical assessment to them.
So this deep dive has really laid out the structure, the language, and the pitfalls. Let's boil it down. What are the 3 most critical lessons? Number 1, route tasks to the correct professional and do it early. Don't delay calling SALT for aspiration or the pharmacist for high-risk meds. Delay is danger.
Right.
Number 2, use SBR. Be rigorous. Include a specific, time-bound ask and any red flags.
Essential.
And number 3, name an owner, set a deadline, and document everything, the referral, the safety net, all of it.
Which really brings up one final crucial question to close that safety loop. What happens if the person you contact declines the referral? Say the OT feels it's outside their scope.
What's the standard then?
The professional standard requires you to immediately clarify, then redirect to the correct service without any delay. And crucially, you have to record that whole rerouting process. You must maintain that traceable responsibility for the patient's safety until the task is successfully handed off.
That's the end of this deep dive. Now you have the WHOTO framework and the precise professional language to handle MDT coordination with confidence and absolute clarity.